we will learn about organophosphorus poisoning, the signs and symptoms of organophosphorus poisoning, and the drug therapy of organophosphorus poisoning. Most patients exposed to organophosphates come into contact with insecticides. Common organophosphorus compounds are ecothiopate, parathion, malathion, diazinon, paroxan, and carbamate derivatives such as carbaryl and propoxyl. Organophosphate pesticide exposure can occur through inhalation, ingestion, and dermal contact. One of the key features of organophosphorus compounds is that they irreversibly inhibit acetylcholinesterase enzyme, leading to accumulation of acetylcholine, a neurotransmitter that is present in the peripheral and central nervous system. Increased concentration of acetylcholine leads to excessive stimulation of cholinergic receptors, namely the muscarinic receptors and the nicotinic receptors. So what is the underlying mechanism of inhibition of acetylcholinesterase enzyme? Organophosphorus compounds are pentavalent compounds and they have a labile fluoride group or an organic group. The acetylcholinesterase enzyme has two sites, the esteritic site and an anionic site. Organophosphorus compound has strong affinity and binds to the esteritic site of acetylcholinesterase enzyme and causes phosphorylation of the enzyme. During the process of phosphorylation, the labile group is released while the remaining group remains strongly attached to the esteric site of the drug molecule via covalent bonds, and this leads to irreversible inhibition of the enzyme. The enzyme substrate complex that is formed is stable and is completely resistant to hydrolysis. So acetylcholinesterase enzyme is totally inactivated and the recovery of the enzyme is dependent on new synthesis which may take few weeks. The enzyme drug complex undergoes a process of aging, which means that within 1 to 2 hours of binding of the organophosphorus compound with the enzyme substrate complex undergoes molecular rearrangement, and this is due to loss of alkyl or alkoxy group, leading to the formation of a stable drug enzyme complex. The enzyme is completely resistant to hydrolysis. So there is no reactivation or no regeneration of the enzyme, and the enzyme is irreversibly inhibited. So what are the signs and symptoms of organophosphorus poisoning? As we have learned that organophosphorus compounds cause irreversible inhibition of acetylcholinesterase enzyme due to the formation of covalent bonding. This leads to accumulation of acetylcholine and excessive cholinergic stimulation of muscarinic and nicotinic receptors. So the signs and symptoms can be categorized as muscarinic actions, nicotinic actions, and CNS toxicity. The muscarinic actions are increased secretions, for example, increased salivation, lacrimation, bronchial secretions, and increased sweating due to stimulation of sympathetic cholinergic nerve fibers. Also, there is miosis due to contraction of the circular muscle of the iris. There is diarrhea due to increased motility of the intestine and urination due to emptying of urinary bladder. The cardiovascular effects are bradycardia and hypotension. Next is nicotinic actions. The nicotinic actions are due to excessive cholinergic stimulation of nicotinic receptors, that is NM receptor present at the neuromuscular junction, and excessive cholinergic stimulation at the neuromuscular junction can lead to cholinergic crisis. This may induce depolarization block resulting in flaccid paralysis and fasciculation. The CNS toxicity is due to inhibition of acetylcholinesterase enzyme in the brain. This can cause symptoms of restlessness, ataxia, convulsions, and respiratory arrest. So what is the drug therapy of organophosphorus poisoning? So what are the general supportive measures in the management of organophosphorus poisoning? These measures include washing of contaminated skin, removal of contaminated clothes, artificial respiration, oxygen administration, maintenance of blood pressure, and so on. Firstly, to reverse the muscarinic signs and symptoms of organophosphorus poisoning, atropine, an anticholinergic drug, is administered. Injection atropine at a dose of 2 mg administered intravenously at an interval of 15 to 20 minutes until full atropinization. So what is atropinization and the clinical criteria for atropinization? Atropinization means is a process by which the muscarinic signs and symptoms are completely reversed, and this is indicated by mydriasis or dilatation of the pupil, which is either full dilatation or at least 2/3 dilatation of the pupil. Secondly, increased heart rate or tachycardia where the heart rate is increased to more than 100 beats per minute. Dryness of mouth and skin warmth are other indications of full atropinization. So what are the undesirable effects of atropine? The undesirable effects of atropine can be categorized as immediate effects and delayed effects. The immediate effects are blurring vision and dryness of mouth, whereas the delayed effects are constipation and atropine-induced psychosis. Injection pralidoxim at a dose of 1 to 2 gram administered by slow IV infusion over a period of 15 to 30 minutes. How does pralidoxim act to regenerate acetylcholinesterase enzyme? As we have learned that acetylcholinesterase enzyme has two sites, the esteretic site and the anionic site. The organophosphorus compound binds to the esteretic site of acetylcholinesterase enzyme. So the anionic site remains vacant or it is empty. So this allows the drug pralidoxim, the acetylcholinesterase reactivator, to bind to the anionic site of the enzyme. After pralidoxim binds to the anionic site, the oxime group attracts the phosphorus atom and helps in the dissociation of the organophosphorus compound from the enzyme. So the compound gets dissociated from the enzyme, and this leads to the recovery of acetylcholinesterase enzyme. However, there are certain shortcomings of oximes. Firstly, oximes are not useful drugs for organophosphorus poisoning if aging has occurred. As we have learned that aging is a process of molecular rearrangement of the enzyme drug complex due to the removal of alkyl or alkoxy group. After aging occurs, the enzyme drug complex is extremely stable and is completely resistant to hydrolysis. The enzyme is irreversibly inhibited through covalent bonding. The enzyme drug complex is highly stable, is completely resistant to hydrolysis, so there can be no regeneration or reactivation of acetylcholinesterase enzyme. Therefore, oximes should be administered as early as possible before aging has occurred, because once aging has already taken place, these drugs are ineffective in organophosphorus poisoning. Secondly, oximes such as pralidoxim are ineffective if poisoning has occurred due to carbamate derivatives such as carbaryl and propoxyl. This is because carbamates bind to both esteretic site and anionic site. So the anionic site is already occupied by the compound, that is the organophosphorus compound. So this prevents the binding of pralidoxim to the anionic site and prevents the action of pralidoxim. Therefore, pralidoxim is not useful in organophosphorus poisoning due to carbamate derivatives such as carbaryl and propoxyl. Thirdly, pralidoxim cannot cross the blood-brain barrier, and since it does not cross the blood-brain barrier, it cannot reactivate the enzyme that is inhibited in the brain. So if CNS toxicity has already occurred, pralidoxim is not useful for treating the signs and symptoms. Other drugs that can be administered are antibiotics to prevent secondary infections. So to sum up, the drug therapy of organophosphorus poisoning: 1. Injection atropine 2 mg administered intravenously every 15 to 20 minutes. Second injection pralidoxim 1 to 2 gram administered by slow IV infusion over a period of 15 to 30 minutes. Next, antibiotics to treat secondary infections.
This brings us to the end of the topic. These are my references. Thanks for watching. Please like, subscribe and share.